And start the recording. Welcome to today's Echo session. My name is Lindsay Zimmerman, and I am with the Tennessee Department of Health, our viral hepatitis program. Just a few key notes before we do get started. We will go over some introductions and announcements for today. Our discussion is a presentation by Dr. David Kursky out of the Northeast Region Health Office, and it's on hepatitis C workup for primary care providers. We will also have a couple of case presentations, a Q&A session, and then, of course, closing remarks. As always, if you have not registered through the SEAETC, that's the Southeast AIDS Education and Training Center, please do so. That assists you in being able to obtain your CEU for attending the session. You can join by using the QR code, or you can also join using the link provided. If you do have any issues with registration, please make sure that you reach out to Claire Bowles. Her email contact information will be at the end of this presentation today. Next slide, please. There we go. All right. And as always, if this is your first Echo session, or even if it's not, please go ahead and drop your information in the chat. We like to see your name, your role, organization, and again, if this is your first Echo session. If you have any tech issues during this presentation today, Kimber Miller has dropped her information in the chat. Please reach out to her to let her know, and we can hope to get that corrected. I'll give just a couple of moments for people to do that. I see very familiar faces and names, so I know that there are several repeat participants, but for those of you all that are new, welcome. I do see that our participation is slightly lower than normal. I'll question if that's due to the bad weather across the state, but I also hope that that won't interfere with our discussion for today's topic. All right, well, we'll go ahead and turn it over to Dr. Kursky.
Thank you. Yeah, so I'm a primary care physician, medical director of the regional health department with Tennessee Department of Health in the Northeast region. We've been doing hepatitis C treatment, myself and our nurse practitioners, for somewhere between 5 and 8 years, maybe a little bit longer. So this is just basically, we use the simplified algorithms, which is what I'll go over. And I'll just tell you kind of like how we do things here. I don't have any financial disclosures or conflicts of interest. So our objectives, we'll talk about pre-treatment laboratory eligibility for simplified treatment, which is really the main thing, just figuring out if your patient is right for the simplified treatment algorithms. Obviously identifying who's not eligible, and then selecting appropriate treatments for patients without cirrhosis or with compensated cirrhosis, and then some ongoing monitoring for certain people. Next slide. Yeah, so I think I stole this from Dr. Chastain, this slide, but just so we're all on the same page, hepatitis C virus infects liver cells. In Tennessee, acute hepatitis C is the main thing that's reportable by providers, which is kind of just the tip of the iceberg of hepatitis C. So most people end up with chronic hep C without ever realizing they had or recognizing the acute infection. So we're going to be talking about treating chronic hepatitis C, which we have a lot of in Tennessee. You can go to the next slide. So, well, one of the first things I discuss with patients when they're come to talk about treatment is just the natural history of hepatitis C. So among people treated with hepatitis C, about 55 to 85% will develop chronic hepatitis. Other people will get rid of the infection on their own, their immune system will. About 20 to 30% will progress to cirrhosis, and then 1 to 5% will develop hepatocellular carcinoma or end-stage liver disease. The next slide is just basically a simplified version of this that's easier to remember when I'm talking with the patients, but we'll just tell them that, about 25% of people will spontaneously clear the infection, 75% will go on, about 75% will go on to chronic infection, 25% of which will develop cirrhosis, and 5% will develop liver cancer or end-stage liver disease. Some things associated with spontaneous clearance of hepatitis C include younger age and infection, female sex, race other than African American, and symptomatic hepatitis C infection. So if you talk to people with chronic hep C, a lot of them never remember having jaundice or anything like that. Whereas people that get jaundice and symptomatic acute infection tend to clear the infection spontaneously. Next slide. So some things that are a risk for progression to fibrosis. So who's going to progress to develop cirrhosis? People that get hepatitis C at an older age, increased age independent of duration. So whether they got it a long time ago and have had it for a long time or just got it when they're older are both risk factors. Male sex, heavy alcohol use, co-infection with HIV or hepatitis B virus, hepatic steatosis, and insulin resistance. So we do screen for hepatitis C in the health department and hopefully in all primary care offices. So the U.S. Preventive Services Task Force recommendations is to screen adults 18 to 79 for hepatitis C virus at least once. So one-time screening for most adults, but periodic screening for people at continued risk for hepatitis C. So people with current or past injection drug use, for instance. They also recommend to screen pregnant adults and also probably any pregnant person you should screen for hepatitis C. So I mentioned that Tennessee, we have fairly high rates of hepatitis C, and there's kind of a gradation going across the state, and East Tennessee tends to have higher rates. When we look at our all the screening we do in our health departments, between 5 and 20% positivity rate for hepatitis B antibody among the people we screen in our health departments in Northeast Tennessee. So, up to 20% of our patients that we screen are positive for hep C. So that's potentially a lot of people. We do have maybe a more high risk population that we see at the health department because of our sexually transmitted infections clinic. But still, there is a lot of chronic hepatitis C out there. So among those 20% that screen positive with the hepatitis C antibody, usually a little over 50% are positive when we test for RNA, so they have chronic hepatitis C. Next slide. One of the issues in our community, and I suspect lots of communities across Tennessee, is there might be a couple of specialists like in the community that are treating hepatitis C, and then a lot of primary care physicians that maybe don't have any experience with doing it, so aren't necessarily treating their patients. As a consequence, even people with private insurance, we treat primarily uninsured patients through the health department. So our patients don't even have Medicaid or TennCare. But even patients with private insurance, less than half look like they're getting treated within the first year of diagnosis for hepatitis C. Again, even with private insurance. So, I think one of the main reasons for this Project Echo is to get more people comfortable, primary care physicians, comfortable with treating hepatitis C because there just is so much out there. Next slide. So yeah, so one of the other thing besides natural history that we talk to our patients about, like right up front, is like why we want to treat hepatitis C. So we are trying to achieve a sustained virologic response, or SVR. So undetectable RNA levels 12 weeks after completing therapy is the goal. So if you can't detect, if someone has a negative viral load 12 weeks after treatment, it's associated with a 97 to 100% chance of being HCV RNA negative long term, and is considered basically cured from hepatitis C. So SVR is associated with a decrease in all-cause mortality, liver-related death, need for liver transplantation, decreased hepatocellular carcinoma rates, and decreased liver-related complications. So yeah, again, we just discussed that up front with the patients to get them motivated to complete the treatment. So the Centers for Disease Control just talks about the need for basically more treatment of hepatitis C to prevent all these long-term complications. So one of the ways to achieve that is through simplified hepatitis C treatment algorithms, which we'll talk about today, that have reduced numbers of laboratory tests and in-person visits. So basically, most patients with chronic hep C that don't have cirrhosis or that have compensated cirrhosis can be treated with just a minimum of office visits and laboratory tests, with very few side effects from the medicines and very high cure rates. Next slide. So probably the main thing for a primary care physician is deciding who to treat. So we do basically cherry pick the easy patients, and then we can leave for the ID and hepatologists, the more complicated cases. So this is our algorithm in the health department setting for basically deciding who to treat, who we're going to treat in the health department setting versus refer to a specialist. So basically, it just requires a basic history and physical, some basic laboratories like a CBC and a CMP, and an INR pregnancy test. Test them for hepatitis B virus infection and HIV. Does not necessarily require, or doesn't require liver biopsy, doesn't necessarily require, in all cases, even like a ultrasound of the liver, although we do get it in patients we think have cirrhosis. So some things that would disqualify patients from treatment with the simplified algorithm is prior hepatitis C treatment. So that will require a more complex drug regimen. So those are people that we would refer to a specialist. Anyone that's HIV positive because of the other meds they're on, and lots of drug interactions with the hepatitis C meds. If they have hepatitis B, surface antigen positive, so chronic hepatitis B infection, because of the likelihood or the possibility of reactivating their hepatitis B, they need to be co-treated or have their hepatitis B addressed. So we would refer them, known or suspected hepatocellular cancer, end-stage kidney disease, decompensated cirrhosis, or prior liver transplant. So those are the people we would refer to specialists. At least in our setting, we don't see that. We see younger people that have gotten hepatitis C through lifestyle choices, but otherwise usually are fairly healthy, except for either substance use or alcohol use. So yeah, those few patients that have any one of those issues, we would refer to a specialist. Otherwise, we basically would do some fibrosis staging based on their laboratory work. So that is done. We do that with something called a FIB-4 score, which there is an online calculator, and I'll talk in a minute about what goes into that. So if their labs indicate basically a high probability of cirrhosis, or they have had transient elastography, for example, FibroScan showing fibrosis, or if they've had a past liver biopsy, or other clinical evidence of cirrhosis like low platelet count, encephalopathy, or other things like that. Then we would go to the next step on the algorithm. You can go to the next slide. Yeah, so FIB-4 score, basically you use their age, their AST value, their platelet count, and their ALT value. And there's multiple online calculators where you can calculate that. So using lower cutoff value of 1.45, a FIB-4 score lower than that had a negative predictive value for advanced fibrosis of 90%. So if it's lower than that, 90%, you have like 90% certainty that they don't have advanced fibrosis. But if it's more than 3.25, there's a high predictive value for cirrhosis. So basically, if a patient has a FIB-4 score more than 3.25, we would consider them to have cirrhosis. And that would take us down a different path on the algorithm. Next slide. So another score that we use to evaluate basically the severity of cirrhosis is the CTP score. So it assigns points for encephalopathy, ascites, bilirubin level, albumin, and prothrombin time, or INR. So basically, a score of 5 to 6 points is compensated cirrhosis and less severe liver disease, whereas 7 or more would be considered decompensated cirrhosis. So there is a simplified algorithm for compensated cirrhosis. So patients you think have cirrhosis but have a CTP score of 5 or 6, we can still treat using a simplified algorithm, whereas patients with a CTP score of 7 or more, we would consider decompensated, and we would refer them to a specialist for treatment. Next slide. So yeah, so we're going down the algorithm. So if they do have an elevated FIB-4 score or other indications of cirrhosis, which would take us down the right side of this algorithm. So we'd say yes. Those patients, one, we would look at their CTP score. Again, if it's more than 7, or if they have evidence of hepatocellular cancer, carcinoma, we would refer them to a specialist. Typically, we would get an liver ultrasound to check for any evidence of hepatocellular carcinoma. A liver ultrasound can also sometimes tell you if they have ascites that you can't detect on your physical exam. So if it's no, then we're going down the side of the algorithm that's treat per simplified treatment algorithm for treatment-naive adults without cirrhosis, which we'll talk more about in a second. If we go down the yes side, if their CTP score is more than 7, or if they have any evidence from their liver ultrasound or otherwise of hepatocellular cancer, we would refer them to a specialist. If not, if they have compensated cirrhosis, we would go down the path of using the simplified algorithm for patients with treatment-naive patients with compensated cirrhosis. Next slide. So again, we've kind of went through this, but this is just the people that would not be eligible for simplified treatment. Um, and again, anyone with decompensated cirrhosis, prior treatment for hepatitis C, because they'll need a more complex drug regimen, end-stage renal disease. Hepatitis B, surface antigen positive, so chronic hepatitis B, current pregnancy, hepatocellular cancer, or liver transplant. Next slide. So the simplified algorithm, I won't go over all of it, but basically this can be found on the website that's listed there, hcvguidelines.org. So basically very easy to follow. It tells you basically everything from patient selection at the top, who to treat and who not to treat, pre-treatment assessment. It tells you to calculate a FIB-4 score, assess for cirrhosis, tells you which laboratories to order for your pre-treatment assessment, reminds us to do medicine reconciliation. So it is important, and we'll talk about later, going through all the patient's current medicines just to make sure there's not any drug interactions with hepatitis C meds, which there's a fair number of potential drug interactions, but outside of patients that have HIV, which we do not treat, I would say there's limited amount of drug interactions, but you do have to be concerned about them. Yeah, and then we do education. It says to educate patients about proper administration of medicines, adherence. We do tell them that their best shot at getting rid of the hepatitis C is to take the medicines every day for the full duration of treatment to have the best chance of having that SVR and getting rid of their hepatitis C. So basically the regimen, there's two different drug regimens that are recommended for patients, treatment-naive patients without cirrhosis. So one is glecaprevir, pibrentasvir, which trade name is Mavoret, and the other is sivosibuvir and vilpatasvir, trade name Epclusa. So you can use either of those. They're pangenotypic. So we have uninsured patients. We don't typically have a genotype of their hepatitis C. So the pangenotypic regimens make it so that we don't have to spend that extra money, or the patient doesn't have to put out any money for that they don't have. So we can use either of those two. Typically, we decide between those two based on one is drug interactions, like what medicines they're currently on, which I'll talk about. And then it also reminds you about ongoing monitoring. So it does remind us that patients taking diabetic medications, there is a potential for symptomatic hypoglycemia. So patients' blood glucose tends to lower on the hepatitis C medicine. And I think it also stays lower. I think there's a whole Project Echo on hepatitis C and diabetes coming up. But they can have some symptomatic hypoglycemia, so you just have to tell them to watch out for that. Also, patients taking warfarin for anticoagulation should monitor their status. That it can actually make them be subtherapeutic, so they may need to increase or adjustment in their warfarin. So those are two things to just remember to tell patients that either on diabetic medication or warfarin. And really, that's about it. We would have the patients take the medicines, depending on which medicine, for either 8 or 12 weeks. The nurse would follow up with them by telephone or telehealth, video conference. And then when they finished the regimen, we would wait 12 weeks and then have them come back to the laboratory to do a viral load to check for sustained virologic response. And that's basically it for treatment-naive patients without cirrhosis. We would advise them about harm reduction. So if they drink alcohol, just remind them there can be ongoing effects from that. If they have fatty liver disease, steatosis, we would encourage them to get ongoing treatment to try to reduce risks associated with that. That's basically it, but it's all there in that algorithm for patients, treatment naive patients without cirrhosis. Next slide. Okay, yeah. So, sorry. So basically the simplified treatment algorithm for treatment naive adults with compensated cirrhosis is mostly the same. There is a couple of differences, which I'll point out. So again, these are patients that have some evidence of fibrosis, but do not have a CPT score of 5 or 6, don't have evidence of any decompensated cirrhosis, either current or in the past. So I guess two of the things that I'll point out, one is in determining the drug regimen for patients with compensated cirrhosis. One thing to point out is that the combination of sofosbuvir, velpatasvir, or Epclusa is the trade name, is recommended for genotype 1, 2, 4, 5, and 6, but not necessarily 3, because there is sometimes some problem with drug resistance with genotype 3. Again, we don't usually get a genotype in our uninsured patients, but you could get a genotype, and then you could still have a choice of either of those regimens. Since we do not get a genotype, we typically try to use, if we have a patient with compensated cirrhosis, try to use glecaprevir, pibrentasvir, or trade name Mavorit in those patients. We do sometimes, like if that's not practical because of drug interactions or something like that, we will kind of just go ahead and get a genotype on the patient's hepatitis C. The other thing to point out is just post-treatment patients with cirrhosis. It is recommended that all patients with cirrhosis have some ongoing monitoring with ultrasound surveillance for hepatitis or HCC every 6 months. So I think those are the major differences between the two algorithms in the algorithm for compensated cirrhosis. So I did mention FibroScan. We used to have access to our own FibroScan in our clinic. It's not necessarily needed for either of these treatment algorithms. You don't have to do this. We did sometimes do it in patients that had kind of a FIB-4 score that was in the gray area between 1.45 and 3.25, where we didn't know which kind of algorithm, which side of the algorithm we should go with them. So it was helpful for that sense. The other thing that FibroScan, which is liver ultrasonographic elastography, the other thing that's helpful is it can tell you about, can estimate steatosis, which is a risk factor again for progression of liver disease even after you cure their hepatitis C. So if you do have access to that, it can help in certain instances, but it's not required for either of these algorithms. Next slide. One thing that you will notice on the drug information for both of the drugs we've talked about is that there's a US box warning about hepatitis B reactivation. So basically, we screen all patients before we treat them for hepatitis C, for hepatitis B. There is a risk of reactivation of hepatitis B. It's very low in patients that are hepatitis B surface antigen negative. But if they do have hepatitis B core antibody positive, meaning they've had past infection, there is a very low risk that they still also could reactivate their hepatitis B. So this is from the Journal of Gastroenterology back in 2018, with a recommendation to proceed with DAA treatment for hepatitis C and evaluate for hepatitis B only if their ALT increases or fails to normalize after therapy. So basically what we do is if someone has again, if they have hepatitis B surface antigen positive, we would refer them directly to a specialist. If they're surface antigen negative, but they have a history of past hepatitis B infection, we would just monitor them more closely during treatment. So we would get basically a liver panel or a CMP once a month while they're on treatment. And then after treatment, also check a CMP when they come back in for their 12 weeks check for SVR. So if when you do that, you see that their ALT is increasing, that would be basically a sign to check for if they have reactivation of hepatitis B by doing a hepatitis B viral load. Next slide. Yeah, I think this says the same thing. This is actually information from UpToDate, which is our point of care information system for our health department primary care providers. Next slide. So again, I said that both of these drugs do have box warnings about hepatitis B. I will talk about another thing that we talk about initially when we see the patient for that initial pre-treatment exam is basically just to talk about side effects. So both of these regimens are very well tolerated. I'm trying to remember, it's hard to remember. I think we have in the past had a patient that didn't tolerate it, but it's very rare that someone doesn't tolerate the meds. So there can be some nausea and fatigue associated with the medicines, sometimes headache. A lot of times patients just with the hepatitis C may have some of those symptoms as well. So we do tell them that usually people tolerate it well if they can get through the first week. Usually they're home free. We do tell them to call us and don't just stop taking the medicines if they're having any kind of side effects, and we can help just talk them through some things to do to be able to complete the regimen. Next slide.
As we go to the next slide, Dr. Kershke, I might just say you might need to kind of save time for the cases at the end.
Okay.
So
thanks. Yeah, we can speed right through. Yeah, so basically the same kind of constellation of symptoms with Epclusa. You can go to the next slide. I will just say and not go through this, that all of this information about assessments prior to starting meds and assessments afterwards is all on that website, hcvguidelines.org. I just have them printed off and in my office when I'm doing hepatitis C treatment that I can just quickly look at these and go to the next slide. Yeah, so this is monitoring during therapy, tells you basically all the things that you need to remember all in one place. You can go to the next slide. So I will mention a couple, I won't go through all the drug interactions. We do use, there are several different drug interaction tools out there. One is the Liverpool drug interaction tool specifically for HCV. Our point of care information system UpToDate also has its own drug interaction tool. And then this is also from hcvguidelines.org, has these matrix with the different side effects. The things that we run into most, one is people taking acid reducing agents. So PPIs like Prilosec. We have had at least one patient fail treatment on Epclusa that was started on a PPI during their treatment. Even though it's like just listed as a caution on this interaction tool, we tried to avoid using Epclusa in a patient with PPI, or try to get them off the PPI if we're going to use Epclusa. The other thing that we like as a common interaction would be some of the statins have an interaction with Mavorette that you would have to consider. And then Mavorette also will interact with certain oral contraceptive pills that contain ethinyl estradiol, which just came up this week in our clinic. So yeah, there are, it's most of our patients aren't on a lot of medicines, but there are certain drug interactions you should think of, and you should always check all of their meds for potential drug interactions. How much time do we have, or are we already out?
We have about 20 minutes left in the session, so if we can.
Okay. Let's see. I don't know. Just go. How about the slide for physical exam?
I think next, there we go.
Yeah. So, yeah, basically, the first thing I do when I talk to the patient is just ask them about if they know how they got hepatitis C and how long they've had it, just to get into the conversation, and then talk about the natural history. During the most people will tell you that they have some history of or past history of injection drug use. But then, like on physical exam, it's just looking for signs of cirrhosis, or asking them if they've ever had, been diagnosed with cirrhosis. Have they ever had ascites, or had hematemesis, things like that. And then on the physical exam, looking for any signs of cirrhosis. Let's see, go to the counseling. We'll wrap this up in the next minute. So we do have to tell people that if we do cure their hepatitis C, they can become reinfected. So having past hepatitis C does not prevent you from getting infected, especially with another serotype. People can become reinfected if in the future they have ongoing risk factors. And we remind them to get that ultrasound every 6 months. Next slide. We talked about follow-up already. Remind them not to drink alcohol. Yeah, lastly, just make sure they're vaccinated against hepatitis A and hepatitis B if they're not already immune to those two things. Because being co-infected can cause lots of problems with their liver. And I'll just end there.
Sounds good. Thank you, Dr. Kershke. And I will say, I'm Shamia, or Mia, for those that are not aware, our viral hepatitis program director at the Department of Health, and will take over facilitation for part of the session now. The slides will be an echo for those that want to see the slides, as it was a lot of information as well. And some of our echoes for those that have been to other ones. Some of our sessions touched on familiar topics as well. So feel free to check out our YouTube for recorded sessions too. So we will pause for a moment for any questions or comments anyone might have. And feel free to come off of mute and ask your question or drop it in the chat. I see one comment that says, "Thank you, Dr. Kershke. You answered the questions I had." So thank you.